everyone. Today we'll be talking about right ventricular failure in the ICU, where I'll be guiding you through the recognition, diagnosis, the hemodynamic assessment and contemporary management. One of the most important key messages that we'll be learning through this presentation is that RV is a flow pump which is very sensitive to changes in the afterload. Any kind of acute change in the afterload is disliked by the RV, which will further result in RV dysfunction. So this is basically the roadmap of my entire presentation. We'll be learning the recognition, that is we'll learn to notice the clinical pattern and the early warning signs that can help us in predicting whether the RV is going into dysfunction, which might lead to severe hypotension later or any kind of organ dysfunction. Then I'll tell you how to confirm it with the help of echo and hemodynamics, and also to recognize various etiologies that might be causing it, which would help us in the management. The stabilization of the patient, which will include proper oxygenation, maintaining of proper mean arterial pressures, the maintenance of preload and the rhythm. To unload the RV, that would help in proper functioning of the RV, and at the end, if these things are not successful, then what to resort for. So the core idea is that RV failure is a circulation problem and is just not an echo diagnosis. Thus, the treatment targets is systemic perfusion and to maintain RV pulmonary vascular coupling. So why is RV failure so important in the ICU? So basically, RV is the final common pathway in any unstable cardiopulmonary disease. So where various ICU contexts where we might be facing RV failure patients is such as in patients in our setup, most commonly it is because of post cardiotomy shock, or it might be in some patients who have undergone for congenital heart disease. It might be because of pulmonary hypertension, or it can be because of ARDS and high ventricular load, or it can be because of RV infarction. Now, why is it necessary to study RV failure? Because RV is a chamber that deteriorates very fast. Why does it deteriorate very fast? Because as I already told that it is a very afterload sensitive chamber. So what happens is once RV faces any kind of increase in the afterload, so it will result in its dysfunction, which will further lead to dilatation of the RV, which might lead to decrease in the LV filling and thus resulting in hypotension. This hypotension will further result in decrease in the coronary perfusion of the RV, further aggravating its dysfunction. Various kinds of atrial arrhythmias will then be poorly tolerated by such an RV, and also that such kind of dysfunction will result in poor decongestion by the RV, resulting in reduced kidney perfusion. So the clinical outcomes, which we will be seeing clinical outcome signals such as high right atrial pressures and low cardiac output, which will predict a very poor prognosis in a patient with pulmonary hypertension, or RV dysfunction. RV dysfunction worsens outcome in patients who have been operated for pulmonary embolism, or patients with ARDS and cardiac surgery, post cardiac surgery, and also persistent congestion can result in organ failure even before hypotension. So I'll tell in a very brief about the RV anatomy that will be relevant for discussing about RV dysfunction. So basically, RV receives its blood from right atria. So the inlet of the RV is formed by tricuspid valve and the chordae, while the outlet is formed by the infundibulum and the pulmonary valve. We also have a moderator band, which also helps in distinguishing RV, differentiating RV from the LV, and also it carries various bundles, nerve bundles, which help in symmetric contraction of the RV. So we need to learn that the RV is now predisposed to pulmonary artery, which is a low pressure system. Hence, as you can see in the inset image, that the RV is a very thin walled chamber compared to LV. So the septum contributes substantially to RV output because a septum is shared by both the RV and LV. Thus, septal motion as well as the pericardial constraint matter in a patient who might undergo RV dysfunction. So a brief about normal RV physiology. So I was already telling that blood from the RV goes into pulmonary artery, which is a very low pressure system. So low pressure means that a pulmonary artery systolic pressure of around 15 to 30 millimeters of Hg, or the mean pulmonary artery pressure of around 10 to 20 millimeters of Hg, which is very low as compared to aorta, to which the LV is being subjected. And also the system is very low in resistance. that is the PVR is usually around 1 to 2 wood units, and it also has large pulmonary vascular reserve, and hence RV is very sensitive to any kind of increase in the afterload. It is also a preload sensitive chamber, by which I mean that it is very sensitive to preload, that is if we increase preload or it needs venous return for adequate functioning, however it dislikes any kind of over distension. Then it is an afterload fragile chamber, as I already told that this RV is subjected to a very low pressure and low resistance system, hence any kind of small increase in PVR can result in marked reduction in the RV output. So if the system is coupled, so the RV stroke volume will be equal to LV stroke volume. Now, to understand RV dysfunction, we need to know that what is RV PA coupling. So it is measured with the help of elastance. The RV contractility is measured with RV and systolic elastance, and pulmonary arterial load by elastance of the artery. So the ratio of RV elastance and divided by the pulmonary artery elastance, if it is around 1.5 to 2, which means that RV is unloading properly and is able to function properly. However, if this ratio decreases by less than 1, which means that the strength of either the strength of contractility of the RV is lower, or the pulmonary artery is giving more resistance to RV to empty, and hence decoupling occurs and the forward flow is restricted. So for adequate forward flow, we need efficient transfer of energy from RV to pulmonary artery. Thus uncoupling in the ICU can occur because of causes which results in increase in PVR, which might be because of hypoxia, hypercarbia or acidosis, or it can be because of lungs, that is atelectasis, or high airway pressures. Now what happens because of this? RV will dilate, as we already discussed that the septum is shared by both the RV and the LV. So the septal shifting will happen, and what will happen, that the RV pressure will increase more than the RA pressure, which will result in TR, and also this will decrease the forward flow, and hence the LV preload will fall, which might result into hypotension. Thus systemic pressures will fall, RV coronary perfusion will fall, and this will result in more RV dysfunction. Thus this cycle will accelerate into shock. Hence when we are seeing the patient bedside, a rising CVP and a falling pulse pressure should give us a clue about RV dysfunction. So what is RV failure? So RV failure is a clinical syndrome and is not only an imaging abnormality. So RV failure occurs when RV cannot either fill or eject enough blood to maintain adequate systemic venous decongestion and is unable to maintain adequate pulmonary blood flow. So this results in forward failure, that is low LV preload, resulting in low cardiac output, while also simultaneously it is leading to backward failure, that is it is not being able to decongest the systemic veins properly, resulting in high RA or CVP pressure and organ congestion. Often both of these can occur together. So where should we look for such things? That is, if hypotension is occurring or there is a need to increase the vasopressor support, we must think that something might be related to the RV. Other clues will be oliguria with a high CVP, or rising lactate and or lower venous oxygen saturation. Hepatic congestion is there, or there is a trend of rising bilirubin, or there is any echo evidence of RV dilatation, poor functioning or septal flattening. So now we will be studying about, I have actually divided the etiology of RV failure in the ICU into 4 parts, that is it can be either because of pressure overload, or it can be because of volume overload, or due to contractility loss, or because of constraint to filling. So pressure overload in the ICU, it can happen because if we are mechanically ventilating the patient and we are giving high PEEPs, or hypercapnia is present, or hypoxia is present, or there is ARDS, that is there is some issues with the lung, or the patient is going into pulmonary hypertension, or it might be pulmonary embolism. Volume overload in scenarios where we have given excess fluid or transfusion, or it can be because of severe TR or PR, or in patients with congenital heart diseases it can be because of residual shunts are there resulting in left to right shunts, or it can be because of anomalous venous return. The contractility loss resulting in RV dysfunction might be because of post-cardiotomy stunning, or it can be ischemia during CPB, or RV infarction, or myocarditis because of sepsis, or any drug-related myocardial depression. The constraint to filling can be because of, in our scenarios, post-cardiac surgery, the patient might have tamponade, or it can be because of tension pneumothorax resulting in increasing intrathoracic pressure, or it can be because of constrictive physiology, any kind of physiology leading to giving stress to the RV in emptying will result in RV failure, because it is already adapted to a very low pressure system. So this is basically the RV failure spiral, the basic this is the most important pathophysiology slide, which tells us about how the RV failure is affecting the body. So basically there are two cycles, that is the central hemodynamic or ischemic cycle, and then there is the congestion or amplifier loop. So as I already triggered, any of the triggers which I mentioned previously resulting in increasing afterload, or because of pressure overload, or because of decreasing RV contractility, which can lead to RV dilatation. This RV dilatation will further lead to functional TR, or and also an increase in the RA and CVP, which will also result in this dysfunction will lead to septal shifting plus decreased LV filling, and eventually it will lead to hypotension and decreased cardiac output, which will further result in decreasing RV coronary perfusion, which will result in subsequently the perfusion which RV is receiving, it will fall, and which will result in RV ischemia and worsening of the contractility. So this will also lead to this functional TR and increased RA pressures. It will lead to systemic venous congestion, which will result in renal or hepatic and gut edema, which will be sensed by the receptors as decreasing function of the renal system, resulting in sodium and water retention, because the kidneys are not able to function properly, plus diuretic resistance, which will result in further volume overload and congestion, and this spiral goes on. So we need to address RV failure at various points so as to counter this dysfunction. Thus, we need to reduce the RV afterload, optimize preload, maintain mean arterial pressures for RV perfusion, restore rhythm, AV synchrony, and also should support RV contractility. So the very important part of my talk is ventricular interdependence. So what happens is both RV and LV, these are enclosed in the pericardium, and hence they share this common septum, which helps them in filling as well as in emptying of both of these ventricles. However, what will happen if RV undergoes any kind of dysfunction, it, as you can see in the picture, so the septum is shifting towards the LV, resulting in a D-shaped LV. Now the cavity of LV has reduced, and also the functioning will be reduced, and hence it will result in decreasing LV preload, because obviously the RV is dysfunctional, so it is not pumping forward flow, plus the volume which LV will receive will also be lower because the chamber size has decreased. So cardiac output, thus it will result in decreased LV preload despite normal LV contractility. Cardiac output can fall after fluid loading if RV distends. This and already that these are enclosed within the pericardium, so this pericardium will magnify any kind of acute RV dilatation. Thus treating RV afterload may result in restoration of LV filling. Now, why is how do we say that despite there will be times when mean arterial pressures are normal, but despite that the organ failure is taking place? So basically perfusion of any organ is not just an entity that is dependent upon mean arterial pressure, rather it is dependent upon the arterial pressure minus the organ venous pressure, which is the perfusion pressure, and in most of the cases this venous pressure is equivalent to the central venous pressure. So what happens is, if a mean, for example, if a mean pressure of 70 is there while a CVP is 8, the gradient is around 62, thus organ perfusion is maintained because of increased gradient. However, if such a patient has a CVP of 24, so the gradient is reduced and hence the organ perfusion is reduced. Thus the for example, for kidney, we can say that in the renal arterial venous gradient falls, which will result in interstitial edema and will worsen filtration. Thus congestive nephropathy can exist despite adequate cardiac output, and in such a patient diuresis may improve kidney perfusion if congestion is playing the dominant part in causing the organ dysfunction. So how to recognize this bedside? So first we can look at the patient and we can see if the JVP or CVP is raised. We can find edema in the patient, we can find hepatomegaly and cool peripheries, denoting that cardiac output has reduced. On the monitor we should see the trends, that is if there is a trend of rising CVP, the pulse pressure is lower, that is pointing towards decreased cardiac output, and there is a need to increase the vasopressors or norepinephrine, and also also if there is decreased urine output, that is oliguria is happening despite normal mean or a higher mean arterial pressures, or even after fluid loading urine output is falling. If we see the gases, then we will find a pattern that is hypoxemia might be present, hypercapnia or acidosis is present, resulting in increasing PVR. And rhythm in a patient who is already very prone to RV dysfunction, rhythm is very important, because such rhythm might predispose the patient to RV dysfunction, that is rhythm such as flutter, fibrillation, block, tachycardia, bradycardia. In such a patient, echocardiography might help, where we can diagnose whether the RV is undergoing any kind of dysfunction with the help of various parameters like dilated RV, septal flattening, TR, or any kind of small LV cavity. Various laboratory clues that might point towards RV dysfunction might be lactates. However, these are not very specific about RV dysfunction, but they can point towards that yes, something is going in the body, something related to the heart is going into the body, and probably RV. So if we are seeing that there is a continuously rising lactate trend, so it points towards either lower perfusion, or it is pointing towards increased adrenergic state. And when we if we are suspecting any kind of function, and we send the BNP and anti-pro-BNP, so these markers, these rise in cases of myocardial wall stress. Thus these might suggest that some myocardial wall stress is going on, and these are also prognostic in a patient with pulmonary hypertension. And we can also send for troponins, which are useful to diagnose ischemic heart, and the in cases of MI or strains. Creatinine can point towards congestive nephropathy or low flow into the kidneys, and bilirubin or rising bilirubin trend can point towards congestive hepatopathy, or it can be because of shocked liver. And we can also measure venous oxygen gradients. So if it is suggesting that if the venous oxygen is falling, which means that there is higher that is the oxygen supply to the organs might be decreased, or there is a high extraction of the oxygen which is being supplied, which is resulting in a low extraction reserve or low cardiac output. Thus, we need to correlate everything, that is the hemodynamics, the laboratory parameters, and the venous congestion, which can cause organ dysfunction even with an acceptable mean arterial pressure. So, various ECG clues that can help us with diagnosis of the etiology includes, for example, if there is sinus tachycardia, RB incomplete or complete RBBB, or right axis deviation, or T wave inversions in V1 to V4, this might point towards RV strain, where a predominant S wave in lead 1, a predominant Q wave in lead 3, and T wave inversions in lead 3 is specific for pulmonary embolism. However, but it is insensitive. RV infarction could be seen, could have an ECG of inferior STEMI pattern or ST elevation in the V4 right lead, which is very diagnostic of that the RV might be undergoing ischemia, or if there is a pattern of block, that is AV block, bradycardia, or hypotension is there with clear lungs, or there is high suspension with RCA territory, there is high suspicion with RCA territory MI. In patients with who have undergone in post-operative post-cardiac surgery patients, or patients who have undergone congenital heart disease patients, they might have rhythms such as atrial fibrillation, flutter, junctional rhythm, or wide QRS in a patient with repaired TOF. Loss of AV synchrony can also destabilize these patients. So, X-ray, we can also do an X-ray if we are suspecting RV dysfunction. It is though non-specific, but it can help us in understanding many things that might lead to any kind of scenarios that we are seeing in the perioperative period. So it might suggest atelectasis or pneumothorax or any effusion, which might result in increase in PVR that might lead to RV dysfunction. Or in post-operatively, it would be helpful in ruling out any kind of tamponade or hemothorax pattern. Oligemic lung fields can tell about massive pulmonary embolism, and also pulmonary edema may suggest that left-sided the role of left-sided component in causing RV dysfunction. Large pulmonary arteries and pruning can also be seen in patients undergoing pulmonary, if patient has pulmonary hypertension. So in these patients, CTPA can also be helpful. They can help us in diagnosing lung parenchymal disease or the severity of ARDS. They can also help us in diagnosing pericardial collection, or if there is any kind of mediastinal issue, or pulmonary embolism burden, or RV to LV ratio can be it can be seen in the CT or CTPA films, and pulmonary artery enlargement can also be seen in the CTPA. CT is definitely not the first step and should not be waited for if the patient is unstable. The first step shall always remain bedside echo. Whenever a patient is going into unstable hemodynamics, the patient is becoming unstable, we see a rising CVP or the pressures are falling, the first and foremost thing that we can do is a bedside echo. So what are the parameters to be seen in the echo? So there, firstly, that RV is a complex structure and thus it has to be visualized under multiple windows. So what we can use is parasternal. First is that parasternal short axis could be seen. So this is the short axis view of LV, where we can see how is the LV cavity, whether it is D-shaped, whether there is any septal shifting, and it can also help us in diagnosing whether it is pressure or volume overload, thus helping us in diagnosing the etiology of RV failure. And also we can see it in apical RV 4-chamber view, where we can see the actual dysfunction of the RV, quantitative measurement of the RV size, the fractional area change, the TAPSE, that is tricuspid annular plane systolic excursion, the S prime, TR and the RA size. We can also visualize in the subcostal 4-chamber view in post-operative patients. That is very helpful in diagnosing pericardial effusion. So any constraint that is offering any increased resistance to RV emptying, or we can also see IVC and hepatic vein. We can see the diameters of these venous systems, which would help us in telling whether the patient is suffering from congestion, whether it is chronic or it is acute. If there usually RA pressures estimate if RA is dilated in our transthoracic echo imaging, so it might point towards that this might have been a chronic problem. And also we can see in the TE mid-esophageal 4-chamber view, this is usually helpful when a post-op patient where windows are limited because of the various dressings and other limitations in the post-op period. Thus TE might be helpful where we can see both the 4-chamber, we can see all of the chambers of the RV, and thus it helps us in diagnosing the tricuspid regurgitation, any kind of dysfunction which is present. We can also see RV dysfunction, and the contractility and the septal motion could be seen in TE transgastric RV views. So the qualitative echo signs of RV failures include RV dilatation. So here we measure the basal RV diameter, and if it is more than 41 mm, it might point towards RV dilatation, which might be happening because of some RV dysfunction. It is just a clue and not any specific indicator that is pointing towards RV dysfunction. If there is any evidence of increasing RV to LV ratio, or there is increased apex sharing, where apex is mostly formed by the LV when apex sharing increases, or we see septal flattening, that is the septum shifting towards the LV, resulting in a D-shaped LV cavity. And usually if this flattening it is present during systole, so it would point towards pressure overload. However, if this is present towards diastole, then it is referring to volume overload. So it is helpful in diagnosing the etiology of RV dysfunction, or it can be because of TR severity. So TR severity can also be measured in the echo, which is a qualitative parameter, qualitative index of RV dysfunction. So functional TR, it worsens RV volume load and lowers the forward flow. The RA-IVC, as I already told, RA-IVC, these suggest the chronicity or market congestion. We can also see the LV cavity, which would help us in diagnosing that whether the LV preload is lower, that is causing decreasing cardiac output, or the narrow pulse pressure, which we are seeing, and also the interdependence could be seen, and pericardial effusion could also be seen in the echo, which particularly in patients with pulmonary hypertension, even a small effusion is a high risk sign. So what are the systolic parameters? That is the parameters guiding through the systolic function, that is the contractility of the RV, suggesting contractility of the RV. So it is first and foremost that we see in every echo is TAPSE. TAPSE is referring to tricuspid annular plane systolic excursion, where we measure that how much the tricuspid annulus has moved towards the apex. So it is a longitudinal only parameter, which is its limitation also. This might be misleading in the post-op period. Normal is more than 17 or 18 mm. However, if it is less than 17 mm, it points towards it is an abnormal value. We can also measure S prime, that is also measured at the annulus level. So if it is more than 9.5 cm per second, it is normal. However, if it is less than 9.5 cm per second, so it tells us about that the motion is not, the RV function is not proper. However, it is angle dependent. And also we can measure fractional area change, that is the area change that is happening in systole and diastole. So if the fractional area change is less than 35%, it is abnormal and is pointing towards RV dysfunction. We can measure the RV free wall strain. Strain is a new parameter which is the lengthening of the RV which is happening, or the shortening, changes in the length which are happening in the various periods of cardiac cycle. So it is often abnormal if less than 20%, but it is load dependence. So there are other advanced echo parameters which could be seen, that is if available they are very useful. Usually these are difficult to obtain. So 3D view of the RV, it is very closer to the CMR than 2D metrics. It the most important part, it does not assume any kind of RV geometry like we see in 2D echo parameters, and but the drawback is it requires image quality and software. We can also, if we are able to measure, then TAPSE, that is tricuspid annular plane systolic excursion by pulmonary artery systolic pressure ratio, should be measured. It is a bedside surrogate of RV-PA coupling. So as I already told, if the coupling is there, then RV function is good. RV is able to empty its, there is efficient transfer of energy from RV to PA. Low values suggest uncoupling. It is affected by TR velocity. And if we are able to measure RVOT VTI, so it is a forward flow marker and it is useful when cardiac output is not available. So T in the ICU, what are the various views that we can see in the ICU for RV? That is mid-esophageal 4-chamber view, where we can view the entire RV and the tricuspid valve. The RV inflow outflow view, these also these are helpful in visualizing the body of the RV as well as the tricuspid valve. The transgastric short axis views are helpful in visualizing the contractility of the RV, and the transgastric RV inflow basal views could be seen. The bicaval views are useful for assessing RA and also for IVC, visualizing IVC and SVC. So what are the questions that we should be asking post cardiac surgery? That is whether it is because of RV, that RV dysfunction is happening because whether the RV is distended, or is it because it is ischemic affecting the contractility? Is the LV underfilled because of RV failure, or is it because of some other pathology? Is there a tamponade or clot compression that is resulting in increased afterload to the RV, resulting in RV distension? Whether the TR that we are seeing, is it severe or is it into the mild or moderate category, or is the PA pressures high or flow low? So how do we assess the, now since till now we have been seeing what is the forward flow which is occurring, whether there is a successful forward flow or not. Now through these parameters we will be seeing that adequate venous decongestion is happening or not. So what is the easiest measure that we see in the ICU? It is usually we measure the IVC. So a dilated IVC points towards a dilated IVC with a poor collapsible IVC, points towards high RA pressures. It is also, however, the drawback is that it is confounded by ventilation and intra-abdominal pressures. Hence, we need to look after the trends rather than a single number. Now this hepatic vein and portal vein can also be seen. So prominent systolic flow reversal with severe TR in hepatic vein flow points towards severe TR or increased congestion. Portal vein pulsatility suggests congestion. Usually portal vein flows are not pulsatile. However, any kind of pulsatility which is present in the portal vein suggests severe congestion. It is useful when kidneys and livers are worsening. This is the concept which is both of these hepatic vein, portal vein concept, and the renal vein Doppler is the concept which is used in the VEXIS scoring, where we evaluate venous congestion. So in renal venous Doppler, if the venous flow is discontinuous, it points towards severe congestion. The presence of systolic and diastolic waves in the renal venous Doppler suggests mild congestion. However, if it is discontinuous, it suggests severe congestion. It can also explain oliguria with high CVP. Thus, congestion plus low perfusion points towards a high risk RV failure phenotype. So now if the shock is complex, now how to identify whether it is because of RV, the shock that is happening to the patient is because of RV, or is it because of LV, or it is because of both? So a entity that can be useful in such cases is pulmonary artery catheter, where numbers can help us to decide whether it is because of RV or because of LV or because of combined RV and LV. So it helps us in seeing RA and CVP waveform could be seen. It gives us additional data on PA pressures and trends. pulmonary capillary wedge pressure, which helps us in diagnosing whether is it because of what is the left sided contribution towards the shock that is happening in the patient, what is the cardiac output and index of the patient, and also helps us in telling it tells us about venous oxygen and oxygen delivery balance, and also tells us about the PVR. So the interpretation pitfalls can be the high PA pressure can fall. This, suppose we are seeing a high PA pressures and it falls, we can think that it is because of a good RV function. However, it can be because RV output fails. CVP alone does not equal preload, and large V waves can reflect severe TR. Positive pressure affects all pressures. Always we need to integrate the echo with clinical response. So what is the hemodynamic profile that we see? We see that the CVP and RA pressures are in a rising trend, which suggests towards congestion, TR, or it can be because of RV diastolic pressures. We see that mean pulmonary artery pressures initially in early phases of RV dysfunction it rises, but gradually falls because RV is unable to include cause forward flow into the pulmonary arteries. The pulmonary capillary wedge pressure, it might be normal or low if isolated right ventricular failure is present. High pulmonary capillary wedge pressure suggests that LV or mitral component might be present. Cardiac index, a low cardiac index suggests that forward failure is present. PVR, it can be increased when the RV dysfunction is after, it suggests that the RV dysfunction is afterload driven. And venous oxygen failure suggests that there is low delivery or high extraction of oxygen. So the bedside diagnostic algorithm for a patient with RV failure will be, if we are suspecting, if we are seeing in the ABG that there is continuous hypoxemia or the monitor tells hypoxemia and the patient has shock and there is a rising CVP, so it should point towards RV dysfunction. What can we do in the ICU? We can put a echo probe, and immediate echo could reveal whether the RV size is increasing or there is any septal shift towards the LV. If there is any septal shifting present, or if there are any clues that point towards RV dysfunction, then we need to identify the trigger based upon whether it is pressure or it is volume overload, or is it because of lung causes or any post-op patient because of rhythm. Then our next step will be to stabilize first. Stabilize the mean arterial pressure, the rhythm, the oxygenation. Then we need to go for hemodynamics. We need to use hemodynamics if diagnosis is unclear. However, despite these measures, despite that we have a targeted therapy towards preload and afterload and contractility, we are unable to improve RV function. Then where do we go? We go towards escalating early towards mechanical circulatory support system or towards surgery. We do not need to wait for complete diagnosis if RV is spiraling. We need to first stabilize the patient.